let's talk about the diaphragm, which is a large, dome-shaped fibromuscular partition. Its main role is to separate the thoracic cavity from the abdominal cavity. Think of it as a kind of boundary that keeps these two important regions apart. The diaphragm is not just a simple divider. It's actually the chief muscle of the respiratory system. That means it's central to breathing. Whenever we breathe in, the diaphragm contracts and moves downward, creating space in the thoracic cavity. This allows the lungs to expand and fill with air. So, understanding the diaphragm is key because it's essential for respiration and maintaining the proper organization of our internal body cavities. It's a fascinating structure that plays a crucial role in our everyday breathing process. This slide doesn't contain enough information. That's why we're moving to the next slide. Now, let's take a closer look at the origin and insertion points of the diaphragm's muscle fibers. The fibers originate extensively, meaning they start from a broad area, which allows for powerful and coordinated movements. These fibers then run upwards, converging as they approach their insertion point. The key here is that they insert on the margin of the central tendon, which is a crucial structure. Just below the pericardium and the heart, this central tendon acts as the central anchor. This strategic positioning is vital because it enables the diaphragm to effectively facilitate breathing by contracting and relaxing, moving the central tendon, and creating the necessary pressure changes in the thoracic cavity. Understanding this connection helps us appreciate how beautifully the diaphragm integrates with the heart and pericardium, contributing to both respiratory and cardiovascular functions. There are three major openings of the diaphragm that we need to understand. Today, we'll focus on the openings of the diaphragm itself. These openings are crucial because they allow vital structures like blood vessels and the esophagus to pass through the diaphragm. Recognizing these is key to understanding how the diaphragm functions in relation to other thoracic and abdominal organs. So, as we go through this, think about how these openings maintain the integrity of the diaphragm while permitting necessary communication between the chest and abdomen. By the end, you'll see how these openings fit into the bigger picture of diaphragm anatomy and their clinical significance. This slide doesn't contain enough information. That's why we're moving to the next slide. This slide doesn't contain enough information. That's why we're moving to the next slide. This slide doesn't contain enough information. That's why we're moving to the next slide. Now, let's take a look at the superior relations of this structure. Superiorly, it is in contact with the pleura and lungs, which makes sense given its proximity to the thoracic cavity. The pericardium also lies superiorly, indicating its close relationship with the heart and the central mediastinal structures. Moving to the inferior relations, the peritoneum is an important landmark because it indicates the boundary between the thoracic and abdominal cavities. Inferiorly, you'll find several vital organs. The liver, which occupies a significant portion of the right upper abdomen, the fundus of the stomach, which is part of the stomach's upper part, the spleen, located on the left side, the kidneys, which are retroperitoneal and essential for filtration and fluid balance, and the suprarenal glands, also known as adrenal glands, sitting atop the kidneys. Understanding these relations is crucial because they help us grasp the anatomical context of the structure, especially its connections and potential pathways for disease spread or surgical access. Recognizing how these structures relate to each other gives us a comprehensive picture of its position within the body. Now, let's talk about the nerve supply. Nerve supply is crucial because it controls the function and sensation of the structure we're examining. It involves specific nerves that innervate the area, providing both motor commands and sensory feedback. Understanding which nerves are involved helps us appreciate how the structure functions and also how injuries or diseases might affect it. Remember, the nerve supply connects the structure to the central nervous system, enabling us to feel, move, and respond appropriately. This connection highlights the importance of the nervous system in maintaining normal physiology and overall health. So, in summary, the nerve supply is fundamental for the proper functioning and integration of this structure within the body. This slide doesn't contain enough information. That's why we're moving to the next slide. The diaphragm is the principal muscle of inspiration, meaning it plays the most crucial role when we breathe in. When it contracts, it moves downward, which increases the vertical diameter of the thorax. This descent creates more space in the chest cavity, allowing the lungs to expand and fill with air. During deep inspiration, the diaphragm can move quite a bit, anywhere from 6 to 10 centimeters, showing how much it contributes to deep breathing. In quiet, normal breathing, the diaphragm is about 1.5 centimeters in movement. This smaller motion suffices for everyday respiration, but for more forceful acts, the diaphragm acts as an important helper. It provides additional power for expulsive actions like sneezing, coughing, laughing, crying, vomiting, or even micturition. Basically, when the body needs a strong, coordinated effort. Before these actions happen, there's usually a moment where the glottis closes, and then the trunk muscles contract powerfully. This combination generates the force needed to perform these expulsive acts effectively. So, in essence, the diaphragm isn't just for breathing. It also plays a vital role in many bodily functions that require a sudden, forceful expulsion of air or other substances. Let's talk about how the diaphragm moves in different positions and what influences its position. The elastic recoil of lung tissue naturally pulls the diaphragm upward, which is an important factor to keep in mind. When you're lying down, the pressure from the abdominal viscera, that is, your internal organs, pushes the diaphragm upwards. Conversely, when you're standing or sitting, these viscera tend to pull the diaphragm downward. Now, while standing, your abdominal wall muscles contract, which increases the intra-abdominal pressure. This added pressure actually pushes the diaphragm upward as well. But in sitting or lying down, these muscles are relaxed, so this effect is less pronounced. Because of these combined factors, the position of the diaphragm varies quite a bit depending on your posture. It's highest when you're lying flat on your back, lowest when you're sitting, and somewhere in between when you're standing. And here's a key point. The higher the diaphragm is, the greater the respiratory excursion, meaning the more your lungs can expand during breathing. Understanding these positional influences helps us appreciate how posture can impact breathing efficiency and overall respiratory mechanics. Let's take a closer look at the development of the diaphragm. The diaphragm, as many of you know, is a crucial muscle for respiration, but its development is a fascinating process. It begins early in embryonic life, around the 4th week, when the mesodermal tissue starts to form the muscular components. These muscle fibers originate from several sources, including the cervical somites, which contribute to the muscle's innervation and structure. As development progresses, these fibers migrate and fuse to form a dome-shaped muscle that separates the thoracic and abdominal cavities. This process is quite complex, involving coordinated growth and differentiation. One key point to remember is that disruptions during this developmental window can lead to congenital issues like diaphragmatic hernias, which highlight how delicate and intricate this process is. Understanding the development of the diaphragm isn't just about anatomy. It ties directly into our broader theme of embryological development and how early disruptions can impact function later in life. So, appreciating these early stages helps us better understand both normal physiology and potential congenital anomalies. Let's take a moment to talk about hiccups, a common but interesting aspect of clinical anatomy. Hiccups are involuntary contractions of the diaphragm followed by sudden closure of the vocal cords, which produces that characteristic sound. While they might seem simple, they actually involve a complex reflex arc that includes the central nervous system, the vagus nerve, and the phrenic nerve. Understanding this helps us see how various factors, like irritation of the diaphragm or nerves, can trigger hiccups. This ties into the broader theme of how our nervous system and anatomy work together to produce even the most basic reflexes. Recognizing these mechanisms can be important in clinical diagnosis and management when hiccups become persistent or abnormal. So, when there's a lesion in the phrenic nerve, it can lead to some interesting and somewhat counterintuitive movements of the diaphragm. Instead of moving normally, the paralyzed side actually moves opposite to the normal side during respiration, a phenomenon we call paradoxical movement. This happens because the affected diaphragm can't contract properly, so instead of moving upward during inspiration, it may move downward or show abnormal motion. This condition is known as diaphragm palsy. Recognizing this paradoxical movement is important because it helps us identify diaphragmatic paralysis, which can significantly impact breathing, especially in patients with underlying pulmonary issues. Understanding these signs connects to the broader theme of how nerve injuries can affect respiratory mechanics and overall function. Let's take a closer look at some types of diaphragmatic hernias. First, the Morgagni hernia occurs in the space between the xiphoid process and the costal origins of the diaphragm, or through the foramen of Morgagni. It's typically located anteriorly, near the sternum, and results from a defect in that area. Next, we have the Bochdalic hernia, which occurs through the pleuroperitoneal hiatus or foramen of Bochdalic. This is situated at the periphery of the diaphragm, around the level of the 10th and 11th ribs. It's usually found more posteriorly and laterally compared to Morgagni hernias. Now, when we talk about diaphragmatic hernias overall, especially congenital ones, they can be classified into these two main types, Morgagni and Bochdalic hernias. Both are congenital defects, but they differ in their location and the way they present. Understanding these differences is crucial, as they help us diagnose and decide on the appropriate management strategies. Connecting these points to our overall theme, recognizing the specific location and origin of these hernias aids in understanding their clinical presentation and potential complications. Let's take a closer look at hiatal hernia. This condition occurs when part of the stomach pushes up through the diaphragm into the chest cavity. It's quite common and can sometimes cause symptoms like acid reflux or heartburn, but in other cases, it might be asymptomatic. The key point here is understanding how the anatomy of the diaphragm normally keeps the stomach in place, and what happens when that barrier is compromised. Factors like aging, obesity, or increased pressure within the abdomen can contribute to the development of a hiatal hernia. Recognizing this condition is important because it can mimic or exacerbate other gastrointestinal issues, and it influences how we approach treatment. Overall, understanding hiatal hernia helps us better grasp the broader picture of esophageal and gastric health. This slide doesn't contain enough information. That's why we're moving to the next slide. Now, moving on to traumatic hernia, which is a specific type of hernia caused by direct injury. In this case, we're talking about hernias resulting from bullet injuries to the diaphragm. The diaphragm, as we know, is a crucial muscle that separates the chest cavity from the abdominal cavity and plays a vital role in respiration. When a bullet causes a penetrating injury to the diaphragm, it can create a defect or tear. This defect then allows abdominal organs to herniate into the thoracic cavity, which can lead to serious complications. Recognizing this type of hernia is important because it often requires prompt surgical intervention to repair the diaphragm and prevent further organ damage or respiratory issues. So, in essence, a traumatic hernia due to bullet injuries represents a direct and often severe disruption of the diaphragm's integrity, emphasizing the importance of trauma management and timely diagnosis in such cases. This slide doesn't contain enough information. That's why we're moving to the next slide.